this article, we show that obesity is present in the majority of patients with heart failure and preserved ejection fraction, and the severity of obesity is a strong predictor of the risk of future heart failure hospitalizations, even though excess body mass is not associated with risk for hospitalization of other causes. My name is Barry Borlaug. I'm a professor of medicine and cardiologist at the Mayo Clinic in Rochester, Minnesota. The article I'm going to discuss, which we've just recently published in Mayo Clinic Proceedings, is Obesity, Cardiorenal Comorbidities, and Risk of Hospitalization in Patients with Heart Failure and Preserved Ejection Fraction. Well, for years, we've known that about half of patients with heart failure have a normal ejection fraction. And in prior years, we conceptualized this as a disorder of hypertensive remodeling of the heart and aging. But in the last 5 to 10 years, we've really grown to appreciate that a large number of patients with HFpEF are obese. And these patients have some key differences compared to non-obese patients, including greater evidence of fluid overload, volume overload, greater intramyocardial fat deposition, and increased abnormalities in venous capacitance. What we haven't known is whether the risk of bad events, such as heart failure hospitalization, is greater in people with greater degree or obesity severity, even though we do know that things like exercise intolerance, impairments in aerobic capacity and fitness, and quality of life are all worse. So in this study, we looked at a large claims database, the LCED database of commercially insured patients in the United States, at the risk, the association between the severity of obesity measured by body mass index and the risk for subsequent heart failure hospitalizations, as well as other types of hospitalization for cardiovascular disease, for kidney disease, or for even infectious diseases like pneumonia. And our hypothesis was that patients with HFpEF would frequently be obese, and that patients with more severe obesity would have greater risk, specifically for heart failure hospitalizations, but perhaps not for other hospitalizations. We also leveraged this database to perform a case control type study. A number of studies have compared patients with obesity phenotype of HFpEF to non-obese patients with HFpEF and shown some differences, but no prior study has really compared patients with HFpEF and obesity to patients with obesity but no HFpEF. So that was the other key aspect of this study. We found that increasing obesity severity measured by body mass index was associated with a graded increase in the risk for heart failure hospitalization over a mean follow-up of about 1.7 years. Which was statistically significant, but there was no relationship between the risks between obesity severity and risk of other cardiac hospitalizations, renal hospitalizations, and in fact, there was even a trend for lower risk of hospitalizations for pneumonia with higher body mass. So it shows that obesity is really uniquely associated with risk of heart failure hospitalization, which is most frequently tied to volume overload and congestion. In that regard, we also saw in the case control analysis that patients with HFpEF compared to age, sex, and BMI matched control patients had more cardiovascular comorbidities, but they also had worse kidney function, and they had greater estimated plasma volume. They had more volume overload. So again, pointing to the importance of congestion in driving the progression to this phenotype of having heart failure. We have a point estimate. We've said for years that obesity is very common. This is the largest study I am aware of in the United States that's not outside of a clinical trial that gives us a good estimate for the prevalence of obesity and HFpEF. It was around 60% of patients. And when you look at the overall cohort, 5,000 patients plus with HFpEF, over 80% of them had either overweight or obesity. So in the United States, HFpEF is really a disorder that is very strongly tied to excess body fat. These findings are important for clinical practice because we know for years, we've appreciated that obesity is a big problem worldwide, but particularly in the United States. And it's strongly associated with a number of diseases like type 2 diabetes, liver disease, sleep apnea, arthritis, and a number of cancers. Um, but we haven't really appreciated that heart failure, in particular heart failure with preserved ejection fraction, is really an extremely important obesity-related disease. And in fact, these data, along with a number of others, really emphasize that the end organ damage of obesity on the heart is really this clinical syndrome of HFpEF and obesity-related HFpEF. These data suggest that treatments that can reduce body weight might be effective to treat their heart failure. In fact, when we looked across the spectrum of obesity severity in HFpEF, as the obesity severity got worse, there were greater cardiometabolic comorbidities like diabetes, and there were higher prevalences of sleep apnea, but there was actually lower prevalence of other things that we see, other entities that we see in HFpEF, such as coronary artery disease or atrial fibrillation. This suggests that the mere presence of obesity is more sufficient to cause HFpEF, whereas in non-obese patients, it's really necessary to have the combination of atrial fibrillation and coronary artery disease and hypertension and all these other risk factors. Whereas if you are obese, that's a big enough hit in and of itself that acquiring abnormalities, other abnormalities such as kidney dysfunction or volume overload can tip you over to developing symptomatic heart failure. For years, we've said that in order to have HFpEF, a person really needs to be above the age of 60 or so. And in a lot of studies, the average age is between 70 and 80. But as we've grown to appreciate this obesity-related phenotype, we now see that these patients are much younger, often in their 40s, 50s, even 30s. And as a rule, if somebody presents with heart failure and preserved ejection fraction at a young age, they are almost always obese. And that was borne out in our data where we saw looking at as obesity severity became greater in the patients with HFpEF, the average age went down markedly. Taken together, this also suggests that that if we can treat the excess body fat, either with lifestyle intervention or pharmacotherapy or surgical therapies, we may be able to substantially improve symptoms of heart failure, and in fact, even the cardiac dysfunction that drives this disorder. So from a patient perspective, these data really reinforce the importance of obesity as a potent risk factor for HFpEF that is uniquely associated with greater risk of hospitalization for fluid overload rather than other causes, and really emphasizes the importance of strategies to result in weight loss, potentially as a way to actually treat heart failure, in addition to all of the other comorbidities that are strongly associated with excess body fat. This is under active investigation in a number of clinical trials. There's a number of exciting new medicines that result in very profound weight loss, along with surgical options, metabolic and bariatric surgery. There's great optimism that by treating the excess body fat, we can really lead to significant improvements and reduce the risk for heart failure hospitalization, which we show in this study is so strongly tied to the severity of obesity present in people with HFpEF. So we're very proud of this manuscript, and we invite you all to read further and learn more about this important topic. And thank you very much for your attention.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us Our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.